Most lung cancers are found too late, when treatment is costly and survival odds are slim. But what if a routine chest x-ray could flag tumors before symptoms appear? AI is turning everyday scans into early warning systems, and it's already changing outcomes around the world. Welcome to CareTalk Executive Features, a series where we spotlight innovative companies and leaders working to advance the healthcare field. I'm David Williams, president of Health Business Group, and my guest today is Prashant Warier. He's CEO and founder of Qure.ai. His company is using artificial intelligence to detect lung cancer earlier. They're dramatically improving survival rates and reshaping how health systems think about screening, economics, and public health policy. Prashant, welcome to CareTalk.
Great. Thanks for inviting me, David. Great to be here.
Outstanding. Okay, now my first question is why focus on lung cancer and what makes that such a defining use case for early detection?
So lung cancer is one of those conditions. My background is a data scientist. So I've been building AI and algorithms, data science algorithms for the last 25 years and got into healthcare with Qure about 10 years ago. And as I was looking at this space, I realized that lung cancer is one of those conditions where early detection actually can create substantial value, right? A stage 4 detection of lung cancer, stage 4 diagnosis of lung cancer, 5-year survival is about 5%. A stage 1, stage 2 detection or diagnosis can lead to about 70-80% survival rates. And so you're going from 5% to 70-80%. And you can go from stage 2 to stage 4 in 6 months to 18 months. So very short period of time, you could get to a late stage diagnosis. And that's where screening matters. If you're able to diagnose early, you could have extremely high survival. And that's sort of the problem we are trying to solve is how, and this is, just wanted to say that lung cancer is specifically one of those conditions. It's the leading cause of death, leading cause of cancer death. And it is one of those conditions where early detection can create the most amount of value. And that's why we focus on this particular problem.
No, that sounds exactly right. So as you're saying, a lot of cases are found late. And if I understand correctly, most cases are often found at stage 4. So it's pretty common that people hear that. First thing they hear is that, you don't have much time to go. How do you think about the cost of the delay, both in human terms and in economic terms? Now, you certainly gave me this kind of statistical difference between, say 5% versus 78%. But how do you think of that, beyond those numbers?
So there are about 230,000 cases of lung cancer diagnosed in the US every year, and more than 126,000, more than half of them die every year. And now again, the people who die might be people who got diagnosed last year, so not necessarily the same set of folks. But there is a substantial amount of people who don't survive, right? And that's one. That's a huge cost. Second is that the cost of treatment of early stage versus late stage is maybe 10 to 20x. Early stage, you can have a lung resection surgery and you could treat it at a very low cost. That could go much, much higher when you're looking at late stage diagnosis. If I look at it, these two are the most common. I would say, the cost of, the mortality due to lung cancer and the cost of treatment, I think these are the two areas where we could improve from a cost perspective.
Got it. Now, there's this CREATE trial. I always love the names with these acronyms for the trials. That always sounds very positive. It's drawn a lot of attention, really worldwide. Why? What's unique about this study that's causing it to get so much attention?
So the basic thing is that look at the problem this way, right? Why is lung cancer diagnosed late? Because patients don't have symptoms when lung cancer is early in the lungs. It's small nodules, small mass. You don't have cough, any symptom at all, right? And by the time you start getting symptoms, it's already pretty late. And it's already a stage 3, stage 4 diagnosis. So the way to diagnose early is through screening, right? And typical screening protocols are using CT scans and are for smokers and people who are either 50 or 55 and beyond. So heavy smokers and people who are beyond a certain age limit. So a lot of times young people don't get screened and non-smokers don't get screened. And what we have seen is that all of them have a probability of getting lung cancer and a significant probability of getting lung cancer. So what we did is we said, and the other problem that we also identified is the fact that CT scan as a modality, I mean, in the US, it is widely available, but outside of the US, especially in countries like India or Southeast Asia, you don't have enough CT scans to do screening. So there is no screening happening there, right? So one of the things we looked at is there are 1.3 billion chest X-rays taken around the world. And that's about 20% of the population. These are people who are getting a chest X-ray for routine reasons. I mean, you could take a chest X-ray for an annual medical checkup. You could take a chest X-ray for an infectious condition that you have, pneumonia or cough or flu or whatever else, right? And we said if we were to create a risk score on these routine X-rays and then identify the right set of patients who could be then triaged for a CT, that could create enormous value. And that is what we did. And we built what is called a nodule detection algorithm and a malignancy risk scoring for that nodule. And now the point is that that score is only useful if you're only identifying the right set of patients who need to be examined further. If you say out of 100 patients, 10 patients need further examination, there is not enough capacity to do that, right? So what we wanted to check was what is the accuracy level of this particular tool? Was it accurate enough to detect the right lung cancer cases? And what we found is that on a chest X-ray, if we identify a high-risk nodule, that patient is 54% likely to have a high-risk nodule on a subsequent CT that is performed. And a chest X-ray is a very basic examination. First of all, these are routine exams. So again, you're not going in to get a chest X-ray for screening, for lung cancer screening. This is something that you did for something else already, for another condition, right? And so we were able to show that 54% of patients who came in for a routine exam and were identified as high risk by Qure then actually ended up positive on a chest CT. So that was one of the key findings that came out of the CREATE study. And the sort of side effect of this is the fact that the people who are getting these chest X-rays are people who may not necessarily qualify for low-dose CT scan screening. These are people who are non-smokers, people who are below 50 years of age. So we are also helping diagnose lung cancer in patients who would not be diagnosed through the typical screening-based pathway.
So one kind of technical question. So beyond the insight of using a chest X-ray, there's also the necessity to be able to see some very small nodules on the chest X-ray that perhaps wouldn't be visible under routine examination. Are you applying some technology in order to be able to find those small nodules?
So what we do is we apply deep learning. I mean, we have millions of scans or tens of millions of scans that have gone into the algorithm to train the algorithm on what a nodule looks like, right? Plus the fact that we have corresponding CTs. So on a chest X-ray, I can see a nodule now. I can also, or maybe the nodule is not clearly visible on a chest X-ray, but I have a corresponding CT where it is clearly visible. So I train the algorithm using corresponding CTs. Plus, I also have biopsy data where I can say that this nodule is actually a malignant nodule. So I am linking my X-ray data with CT data and biopsy data, and that allows the algorithm to now learn what a nodule looks like. I mean, and it can detect really small nodules, hidden nodules behind the heart shadow, behind ribs, and also identify which kind of nodules are likely to be malignant, which is again something that on a chest X-ray, radiologists find hard to do. So we do both these things. And the algorithm works because it's seen a lot of X-ray data, and it's seen a lot of paired X-ray CT biopsy data as well.
I want to go back to something you just said before and kind of emphasize it, which is the population where you're actually finding these lung cancers. Now, most people think about lung cancer as something you get from smoking, and smoking certainly causes lung cancer. And so after a lifetime of smoking, people get lung cancer. That's got a traditional view. And there are a lot of people like that. But let me know if this is right. So it sounds like that you detected cancers, 59% of the people where you detected cancers were actually non-smokers, and almost 10% of them were under 50. Now, those people I don't think would get screened, including not just in a low resource area like Southeast Asia, but maybe in the US as well. So is that right? And then what does that tell us about how we should be thinking about the screening guidelines?
No, exactly right. And in fact, I mean, this is something that we are now scaling up across the health systems in the US, where incidental detection on chest X-rays is becoming more and more common as we deploy our solutions across the systems, right? And the data that you presented is exactly correct, right? Out of the number of cancers that we detect, 50% of the cancers are detected early. And typical numbers are 80-20. 80% are detected late, 20% are detected early. We are talking about 50-50, 50% early, 50% late, right? 59% of the cases are non-smokers. I mean, which they would not go through screening at all. Around 10% are under 50. Again, these are people who would not go through screening. And this, I think, the reality. And coming back to the question that you asked about screening guidelines, right? The screening guidelines are set in a way that you have limited CT capacity. You can only CT scan so many more people, because this is not a person. This is an elective procedure, right? This is not something where somebody needs to get a CT. I mean, this is something that you have to do on an annual basis going forward. I mean, so you don't have enough capacity to, let's say, if you decrease that number 50 to 40, there might be, like, let's say, 5x more people who need to be screened, which you may not be able to do, which any health system may not be able to do. So those screening guidelines are set in a way where there is enough capacity to perform the screening. But that said, I think what we are trying to do as Qure is to look at routine exams, whether it be a chest X-ray or a chest CT, or even look at electronic medical record data, and see if there are risks that we identify that can be flagged for that patient to then get a CT. So now you're not screening somebody who has got no symptoms or no risk of lung cancer. You are actually screening a high risk population. Versus regular screening is, okay, anybody above 50, anybody who's got 25 pack years of smoking goes and gets a CT. Now you're changing the paradigm to say that I will basically look at people who are high risk and get them a CT, right? And this might, I mean, again, we are early in this, but this could potentially change screening guidelines over the next several years. But right now, screening protocols are all low dose CT scan driven, and for the near future, I see them remaining that way.
Now, you've implemented this AI lung screening in a couple of places, in Goa, in India, and also in El Salvador. And I'm wondering, what kind of lessons have you learned from doing these rollouts?
I think the key couple of lessons, I mean, multiple lessons that we have learned, right? One is that in Goa and El Salvador, what we have done is basically every X-ray machine, every X-ray that is taken automatically comes to Qure. So one is that you basically saturate the system. You anything that is any scan that is taken, there is an ambient. Think about it as an ambient AI, right? It's just there and looking at everything, every scan that is performed, whether it be a chest X-ray or a chest CT, right, and making sure that only the right set of patients get flagged for further examination. So one is that the ambient AI use case needs saturation, needs to work across all of the hospitals in a system. Second thing that we learned, very important, is the fact that I can flag as many high-risk patients as I want, but unless there is a follow-up performed, there is somebody who's ensuring that there is a CT that is done for that patient, it's not very effective, right? So follow-up is super critical, and follow-up requires two things. One is that we have to integrate with the health system, their IT ecosystem, their EMRs, their packs, to ensure that there is a follow-up created within the IT systems. And second is that patient navigators are super critical. I mean, there are nurse navigators who are calling those patients, getting them back for a CT. And what we realized is that we are building AI for the doctors, but we are also building AI for the nurses. And we need to ensure that they have all the right information to make sure that the patient knows that they have to come back for a follow-up examination, which is a CT, after the high-risk X-ray that we identified. So learnings again, one is the saturation across systems. Second is integration with the IT systems in the hospital. And third is ensuring that we build an AI for the nurses as well, not just for the physicians. And that's an area where I think not a lot of companies are focused on that particular problem.
Prashant, I was reading an article the other day, and it was talking about how Western drug companies in particular were developing products, and a lot of the trials were done in lower income places like India, like El Salvador, but then that a pretty small percentage of the therapies, once they got on the market, were actually available there. So they were developed in these places, and those were the insights were generated and the evidence, but then they weren't available there later. Are you following a similar path, or should we expect something different?
No, our products are available across 105 countries. We're actually deployed across about 4,800 hospitals in 105 countries. And There is, like you mentioned, Goa, state of Goa, which is in India, El Salvador as a whole country. We are in every sub-Saharan African country. We are in all countries in Southeast Asia. We are in UK. We are in many countries in continental Europe. We are in US and Canada, Latin America. So I think the good thing about AI is that you can deliver it anywhere, and I can deploy it in any hospital anywhere in the world in a matter of a couple of days, or in actually even a matter of a couple of hours, right? So AI that way is something that can be easily deployed and scaled, and our technology is available universally.
Great. So if you're advising a health minister, let's say for a country that hasn't yet, or a region that hasn't yet implemented this technology, what do you tell them, or what would you tell them about how to be most successful in the rollout?
I think my and having sort of worked on deploying Cure solutions for the last 5-6 years across health systems in many parts of the world. I think my advice to a health minister would be that look at the end-to-end um, workflow that is required to deploy AI. AI itself will not be successful unless and until you think about what the follow-on effects of that are. So, for example, in the lung cancer case, if we say that this patient needs a follow-up CT, now you need to have the capacity to do that CT. You need to identify the machine or the hospital where they're going to get that CT scan done. You need to have a mechanism to arrange that schedule that appointment. You need to have a nurse navigator who's following up with that patient to get them back for CT. So that whole ecosystem needs to be enabled to deploy to make the AI successful. AI itself is great technology; it can add a lot of value, but you need to get all the other pieces also figured out.
Prashant, that sounds interesting in terms of the health minister. Okay, that's good. Any other key to success for them?
Yeah. I think one thing which I also want to add is the fact that, like I said earlier, there are 1.3 billion chest X-rays taken routinely around the world, and these are exams where you could actually find a risk of lung cancer. And a lot of times, a lot of health ministers, especially in emerging markets, think that there is not enough CTs, and so you cannot have early detection of lung cancer because you don't have enough CT machines or capacity to do low dose CT scans. But this is a data set that is already available, that is already being taken for so many reasons. And you could now, with our technology, you could be diagnosing lung cancer early. You could be creating programs. Not necessarily. Calling it screening is probably not the right word, but you could have early detection mechanisms using an X-ray based pathway.
I think that's very helpful, and I hope that people will take it to heart. You discussed before the importance of the logistics, especially the follow-up and making sure people have access to that so that the rollout is successful. And you mentioned that with AI, it can be deployed, very quickly at scale. Now, one of the challenges is about the role of the clinician and what trust they may have in the AI for themselves and also for their patients. And we've seen in some places around the world a concern about, hey, I don't like AI, or I think it's going to, I don't trust it, or I don't understand it. It's a black box, or it's going to take my job, or the patient doesn't like it. Is that a factor? And how do you think about earning the trust of the clinicians when you're introducing AI into these workflows?
So it's a great question, actually. And this is something that we have been figuring out. Actually, this is one of our biggest learnings over the last 10 years, right? And the first thing is that, you have to understand what you are promising. Trust is created if you promise something and deliver that consistently over time, right? And a lot of times when people think of AI, they think of something that is going to be 100% accurate all the time. That's not the case. You know that AI is playing a role in this, right? It's flagging those patients who may not have been flagged further for examination. So you might have some false negatives, but you want to reduce the number of false positives here, right? In this particular example of lung cancer screening. So we know how to position the AI to the physician so that they can extract the maximum value out of it, whether that be saving them time, whether that be identifying the right set of patients who need a CT examination, or finding something which they would have missed or they don't want to do. For example, quantifying lesions in a CT scan is an extremely cumbersome process, time-taking process. And we can do that automatically in a very short amount of time. AI can do that automatically. So that becomes extremely valuable for a radiologist, for example. So I think identifying the right value proposition, uh, pitching that, and delivering that consistently over time, that creates trust. And once there is trust, then things, work very well.
We've been discussing a lot here global impact and the impact on national or regional health systems, which is amazing because it's something that can impact a lot of people. But of course, each one of these diagnoses comes down to a particular individual and their family. You've highlighted a patient named Diane in the UK, and she had an early diagnosis. It came from an AI alert on a routine x-ray, which is the kind of thing that we're talking about here. But help to personalize that story a little bit. What does that story tell you about, the potential to do things differently in the real world?
So the key of that story, right? That's, of course, that's one data point, one story, right? But one story means a lot to that person, to that family, right? And what we are seeing at Cure is we have now hundreds of such stories that are coming out, patients that are diagnosed in El Salvador or in India or in the US. And I think from a data standpoint, I think the key is that in the UK, the average turnaround time for lung cancer diagnosis is about 65 days, right, to start treatment. And we were able to bring it down to 25 days with our technology. And this time, the 25 to 65 days, a lot of it is scheduling, a lot of it is not getting a CT scan on time. And by triaging that this patient needs a CT, we are ensuring that that delay is not happening, right? And we are ensuring that nurse navigators are able to prioritize this patient, get them triaged on time. And Diane is one example, but yeah, you could have hundreds of thousands of such patients who could be diagnosed early if you had used Qure.ai on scans that were taken for routine reasons. And our goal is to prevent 100,000 cancer deaths in the next 5 years.
So sometimes sort of bringing it back to an individual story, you go to the doctor's office, they give you a good report, or they say, gee, there's something a little concerning to be able to look at. And one of the concerns in the past has been perhaps if you've got something and you're worried about it, and it turns out, well, it wasn't anything I needed to worry about after all, and so it was all that for nothing. Or even if you do a more invasive test like a biopsy, that you might have pain, even some serious side effects and all that. So I'm just thinking about kind of like the overall rhythm of it. It sounds like what you're describing here is routine chest x-ray that you were doing anyway for some other reason. And then it's almost like an incidental finding, except you're doing it in a systematic way. And then the follow-up, as you've emphasized a couple of times, is a low-dose CT. So not a big deal. And then you get the turnaround. How quickly do you get the turnaround from the read of the CT?
So I wanted to answer your first question, which is a super important question, right? That this is exactly the point of what the CREATE study that you asked about. That is what we're trying to prove, right? If you create a lot of false red flags, right, and somebody doesn't have cancer, if you have 10 people that you flag, and out of that, 9 people don't have cancer, don't have a risk of cancer, you're unnecessarily scaring them. So your technology has to be super accurate, and that is where the 54% success rate on that we got in the CREATE study is super important. That out of more than 1 out of 2 patients are actually positive on the CT, right? So that number is super critical when you look at screening or look at identifying the right set of patients for the low-dose CT scan. Now, the low-dose CT scan turnaround, honestly, it's something which depends on the system. You can get a report in 1 day to 1 week, but system to system, it might differ. Radiologists will typically report in a day. Ideal number should be about a day or two.
Prashant, at the start of the podcast, we started off talking about, why lung cancer. And it was pretty clear. It's a fairly common and a deadly disease where if you find it early, you can do something about it, as opposed to if you don't, it's a problem. People already have, they're getting chest x-rays fairly routinely. That turns out to be a good modality for being able to pick things up. Now, it's been a few years since you did that and picked that out. Technology has changed, treatments have changed. And so if you look today, is it still lung cancer as like a singular cause, or would there be other conditions where you'd also be looking at this AI-driven early detection? What's next, in other words?
So this is something that we have been thinking about all the time, David. We process about 20 million scans across the world, 20 million chest X-rays on an annual basis. And what we have been thinking about is what else can we detect early on these routinely taken chest X-rays. And a few things that we identified. One is chronic obstructive pulmonary disease. It's again one of those conditions which gets diagnosed late, and early detection can have substantial value. Right? So that is something that we built out, detection of COPD, just like our lung cancer product. And that is something we are scaling up now. We built out the technology. We're scaling that up now. There are a few other areas. I mean, looking at detecting heart failure on a chest X-ray. So you can see some signs of that. And we have some technology around that. We are still sort of testing that, doing the equivalent of the CREATE study that we spoke about to see what the value of that would be. And then there are some more conditions that we are working on and will probably announce in the next couple of months. But as Qure, our focus is on using ambient AI on routinely taken exams, whether it be a chest X-ray or a chest CT, to diagnose disease early. And that has been our focus. That will continue to remain our focus for the next couple of years.
That's a great theme to be pursuing. And of course, the economics of doing that do differ by condition and by country. So with lung cancer, as you're saying, if you don't detect something early, it could proceed pretty quickly to death. COPD, just even the first word of it, is chronic. So usually, a few months delay in diagnosis are not going to be fatal. However, there are some good drugs for COPD, and it's underdiagnosed. And so, at least in the U.S., which I can speak to, more COPD diagnoses also has a good economic outcome for a good clinical outcome for the patient, but also potentially good economic outcome for some other players, and that's going to vary around the world. What is your vision? I've talked about the rollout of the lung cancer screening. What's your vision for how you integrate AI into national health systems more broadly?
One of the biggest issues that I see with integrating into national health systems is that the nations also have to think about how they are adopting AI. And there is a lot of different kinds of AI that is available right now. And I think having nations need to have clear strategies on what kind of AI that they are deploying and how they're deploying it directly with companies like Qure or through platforms. And what is, like I mentioned earlier also, what is the follow-up action from that, and how do you enable the follow-up action that comes from deploying AI solutions here? So I'm seeing that, for example, UK NHS has a very well thought out AI strategy. I see that in the US, I mean, not from a national perspective, but a lot of larger health systems have thought out very well thought through AI strategies. I think many nations are still figuring that out, and I would say that's the primary one, is to figure out what is the strategy to deploy AI in the health system. We are always happy to work together if there is an opportunity.
Prashant, I know as a patient it would be great to get this early detection, and if I had cancer, to find out about it and do something about it. But one of the problems with healthcare around the world is that you add things, maybe it's good for the patient, but it adds costs, and it's already kind of unaffordable. I mean, is there a business case for doing this, or is it just sort of one more cost in the health system?
That's again a great question. I think one of the things that I wanted to add is that we are not adding screening cost, right? The kind of technologies that we're deploying, these are ambient in nature, running on routine scans. So there is no additional X-ray or a CT taken. There is no additional cost there. Second is the cost of treatment. Again, what we are seeing is that early detection actually reduces the cost of treatment, does not increase the cost of treatment. And it actually increases the lifespan of the patient. So it is good for the patient. Cost-wise, it is good for the government or the health system. And it's not adding more X-ray or more investigational cost, more X-ray or CT cost. So overall, I think early detection of lung cancer or some of the other conditions adds positive value to the health system.
Well, that's it for another episode of CareTalk Executive Features. My guest today has been Prashant Warier. He's CEO and founder of Qure. His company is using artificial intelligence to detect lung cancer earlier, dramatically improving survival rates without breaking the bank. I'm David Williams, president of Health Business Group. If you like what you heard, please subscribe on your favorite podcast platform. And thank you, Prashant.